Hey, Daniel, how's it going?
It's good. Happy Friday. I'm always doing Friday recordings. I always start out with that. But how are you doing today?
I'm doing all right. I was telling Patti and Marcy earlier today that I haven't been sleeping. So
Oh,
I got to show Patti what I decided to knit. And then last weekend, I took my mom to Olympia, Washington, and we did a weaving class. That was interesting too. So I guess I'm going to be a knitter and a weaver when I can't sleep at night. So watch out, Christmas presents. That's all I have to say.
you're going to compete with Gretchen for like the top knitting and knitting award for the company.
I'll never be at Gretchen's level. I'll just be she's amazing. All right. Well, should we kick off this episode?
I think we should. You want to go over the title and maybe a little context for why we thought of this?
Yeah. So this episode, we're recording episode 21, marriage between pricing transparency and patient estimates. So we're hoping with our guests today that we can dive in and really understand like the complexity of pricing transparency coming from CMS and the new regulatory requirements that continuously are growing, and get their take on, hey, are patients actually getting any value, or is this just creating a lot of extra work for our teams, and where should the work actually be pointed? So get their individual perspectives, not necessarily perspectives of their companies, but both of them are leading experts in the industry. So I'm excited to have them today.
Cool. Well, let's introduce our guests today. Introduce our first guest, currently a treasurer and board member for NAHAM. So for folks that have been listening, we had a lot of NAHAM guests. That's exciting. And then bringing over 19 years of experience in revenue cycle and healthcare access services, and then currently the system director of patient access at the University of California, San Diego Health. Multiple HFMA certifications, as well as CHFP, which is Certified Healthcare Financial Professional. We'll need to cover all these acronyms at some point. But thanks for joining us today, Jacqueline.
Thanks for having me. It's great to be here.
And I screwed up there, Daniel. Jackie is actually the chair of strategic projects now. She's no longer the treasurer. I did the update on my call sheet, forgot to send it to you. That's my bad.
Well, hopefully that role is exciting, just as exciting as the treasurer role. So
it is. Thanks.
All right. Well, we have another former board member of the executive board of NAHAM joining us today. They also have been a prior female and revenue cycle leaders to know from Becker's for 2017 and 2018. Also recently published, nationally recognized for a lot of her publications with several different business partners that she engaged with when she was back in Texas, leading a multi-system patient access. She is our director of growth and business development here at Wilshire. Welcome back, Patti.
I'm excited to be back. Thank you, guys.
All right. So before we jump into talking about patient estimates and price transparency, all the good stuff that we want to chat about today, since you all are both very involved in just healthcare access management at an executive leadership level, thought you could share a little bit about your growth, professional growth, with NAHAM, HFMA, or anything else. We have a lot of early careerists on the podcast that listen, and oftentimes the question is how did you get to where you're at today? So Jackie, do you want to start out just giving a little bit of background on what has really driven your professional growth over the years?
Sorry.
I was like, we stumped her.
No, you didn't. But I'm making sure I'm reading the right call sheet because I didn't see that on mine.
Oh, yeah.
Just FYI, I thought we were talking about NAHAM and HFMA.
Yeah. And how has it impacted your growth?
Oh, got it. Okay.
Yeah.
Clearly, I need to finish drinking my Starbucks coffee that I have not finished drinking today.
It's okay. I think
the shot that I got 20 minutes ago.
Could be the combo.
It's probably the combo. So with my professional growth and being part of both associations at NAHAM and HFMA, they're well-known professional associations supporting access services and healthcare finance. Being a member of NAHAM has allowed me access to their many tools and resources to patient access. I've been able to grow as an access leader by staying up to date with different industry trends, ensuring operations are meeting key performance indicators. And the Access Keys, which is a series of 35 KPIs that measure how well front-end departments and staff are doing across different domains of patient access, is one example of really the many benefits from NAHAM. I think with HFMA, I've been able to continue to grow professionally by learning how revenue cycle as a whole really works, and then the impact that my front-end operations has over the ever-changing healthcare environment. I think the networking benefit is amazing. Being a part of these associations has helped me personally build connections with others in similar roles. And oftentimes I'm really able to reach out to them, pick their brain, which is always nice to have a team of experts available when needed. So, yeah.
Hey, Jackie, what type of certifications have you been, have you seen as you've grown as a professional? That kind of, where'd you get started with the certification realm? And, was it more NAHAM or was it more HFMA? And then kind of that progressional growth, we know that you have your CHFP from HFMA, and that's kind of the all-encompassing hard one to get. I have yet to pass the first test, sadly. Partially because I don't study long enough, but we know that's one of the harder ones to get. So, what was kind of your growth to get to that point of getting that certification that now you have to maintain through, getting continuing ed credits?
Yeah, so I started with NAHAM, to be quite honest, right? I was patient access. I was really trying to master that trade of patient access. And so NAHAM really encompasses everything front end. And so I started with my CHA. So they offer two different certification programs. One is your CHA, which is the Certified Healthcare Access Associate. And that's more for front-end associate levels, those without direct reports. And then I moved on as I became a leader in access services with direct reports and took my CHAM, which is the Certified Healthcare Access Manager. And so it really, both certifications allows you to really validate that your knowledge and skills align within industry standards. And so that's kind of where I started. Then I was fortunate enough to work for an organization, and I still do work for an organization that has an enterprise-wide membership for HFMA. And so because as part of that membership, you're allowed to take the different certification programs, I went on to then take my CHFP. I was a little intimidated by it when I read the program. I didn't know, if it was going to be something that I would pass or how much I would really learn and apply in my current role. But the program overall is really quite amazing, and it helped me learn have a deeper understanding of the financial realities of healthcare. And then how, once I learned, through that program, I was able to apply those ideas on the different financial strategy and then different insights into future trends, et cetera. And then the CRCR is newer for me. I took it recently to set the example because I wanted my leadership team to take that certification. And so I felt like I needed to lead by example. And so I went ahead and took the CRCR.
Awesome.
Yeah.
Hey, Patti, how about you? Oh, you're on mute.
Very similar to Jackie. Started off, on the front end in patient access before I became a director, and I took the CHA certification. And then once I became a director, I took the CHAM and became active in NAHAM. Started on their membership committee and branched out from there. I think I've been on every position that there is, except for secretary and treasurer. Been president, vice president, a delegate, national delegate. And it's been great. It was a little scary at first to decide to jump into one of those positions because, you don't know a whole lot of folks when you first start out. But it's very rewarding once you do join a committee. And committee is probably the best place to start out and then branch off into those other positions. But definitely being part of your trade organization is extremely beneficial to your role, because as you do things and need to justify certain things, it's good to have that backing behind you. to be able to reach out to peers and network and others, and be able to show your CFO that you've got, you know, a good solid foundation behind your request, and you've done due diligence in that, you know, in that regard. So yeah, no, being part of an organization is great.
Yeah, I really enjoy, Patti, the NAHAM educational offerings, the different on-demand webinars, and then their toolkits are always really awesome. I think for me as a leader, it's one of my kind of daily go-tos whenever we're talking about anything, such as when COVID had happened, right? I knew that NAHAM had this disaster toolkit that I could take a look at and see what I could glean from it. They have leadership toolkits. They have the Joint Commission toolkit, just to name a few of them. But I think that the networking for me, as scary as it was when I became a member and went to my first conference, and I went alone, no one else from my organization had attended. I was super excited to be there, but I was definitely shy. But the great thing about NAHAM is I was able to meet people like you, Patti. I still remember the first time that I met you. I think it was back in 2014. And everyone just helps you feel so welcomed. And because we're all so passionate about patient access, it just makes it that much easier to really feel like you're part of a big family when you're there. So it's awesome. So if you don't know, NAHAM's going to have their 50th annual conference. It's being held in Dallas, Texas, April 23rd through the 26th of 2024. And like we said, it's a great way to keep up to date with industry trends and meet others in patient access and build your network. So hopefully we'll see you attend.
Did you do that shameless plug? Good job.
I did.
I'm being awfully quiet on the podcast because I've never been to a NAHAM or an HFMA conference, so maybe I need to go attend.
You should.
So as you guys look at, you know, developing your patient access or your healthcare access, as we're now referring to them, since it's covering beyond just the hospital setting, and we're seeing more and more front end teams in the professional environment start to adopt what best practices hospitals have had. Where do you guys start off with your staff and like looking at certifications or their own individual growth around, you know, engaging into one or the other or both organizations?
Jackie, do you want to take it, or do you want me to go first?
Yeah, do you want to kick us off first?
Yeah, I mean, from my perspective, I utilize both areas, HFMA and NAHAM. I would look at NAHAM first because that's their primary trade, is the patient access, you know, area. And so we would always look at the CHA certification. I know a lot of facilities have that CHA certification built into their STEP program, or their levels, or some type of a pay increase or whatever. They've built that in somehow, which is really good because it really it makes sure that the staff know what they're, you know, what you're talking about. HFMA, we would branch out into HFMA, the revenue cycle training. We'd look at financial clearance, those type of training classes. Yeah, for sure. We would use both for certifications. And not only for individual, for staffing, but for just processes in general. For example, HFMA has their patient financial communication best practices. A lot of hospitals a couple of years ago, they went down that road and mastered that, which was pretty, you know, pretty extensive as far as going in and making sure you had the right forms and the right communication, the right information. And, you know, I think at the time there was only like 10 or 15 hospitals that got that certification, but it was a, you know, it was a big kudos to that hospital for going that extra step. And FMA does that a lot with different programs.
Yeah. I think, you know, different organizations kind of use different tools and different associations differently. I think it just really depends. I know here at the UC, one thing that I'm really proud of is we were able to add different career levels in patient access. So it allowed us to have the entry level staff come in, where we're really just looking that you have at least a year of customer service experience, really important on front end facing, patient facing roles. And then we do have requirements, as you move up the career ladder. So if you're like a level 3, as an example, we'll want to make sure that you not only have similar experience with the same size organization and type of healthcare organization, but we will look to see if you have any types of certifications. And so typically for front-end roles in patient access, the CHA is definitely one of those that will push your resume to the top, as well as, if you have an undergraduate degree or any type of college experience. Patient access as a whole doesn't necessarily look at an individual with like the CRCR, but it is a benefit because it tells us as employers that you understand more revenue cycle as a whole, which is super important.
As you guys are building out your patient access, career, I'm going to call them career ladders versus in that regards. I know, Jackie, you and I are engaging on soon we'll be engaging on a project across all of the UCs, looking at how we leverage HFMA to create our career ladders and those certifications, knowing that we're going to have a little uniqueness in the patient access realm versus maybe, back-end billing where they could go right for their CRCR. Are you thinking in your light and I know I'm throwing this on the spot on you, starting off with CHA and then moving to CRCR, or is it one or the other, or either one kind of suffices, trying to look at what are those metrics and measures that we're going to tick to say, hey, you're moving from a patient access, rep 1 to a 2 to a lead to a supervisor. And eventually we need you to have this level of credentialing and educational background before we throw you into a management type role.
Yeah. So I think definitely for me, the CHA has always been really important because when especially if you are just starting out in patient access, if we're talking entry level, level 1 and 2, I think they need the fundamentals, right? And that's what the CHA really does for you, right? You're able to study and understand front-end patient access specifically, which is key to that individual's success. Whereas if we're looking at maybe not necessarily a level 2 or 3, but a lead position or even our supervisory positions, I think that's where the CRCR really comes into play, because they do need to understand the front end operational impact to all of revenue cycle. And that's where the CRCR is amazing because it has different programs that cover the front end all the way through the back end, SBO, etc. And I think, as people advance in access services and potentially into other revenue cycle roles, that's when that certification really will come into play.
As a naive listener, I'm going to pose this question to the group. Thinking about like certifications, that can be like a scary word for some people when they think about, I have to do all these tests, these classes, studying, etc. Is this like a something that somebody can like manage within their full-time job, or is this like something that we would expect someone to do like extracurricular studying?
Yeah, I mean, I think that supporting our staff with growth and development is super important. So I would say, as if a really great leader, you would allow staff dedicated time to be able to grow and develop. And so, while I would never stop anyone from pursuing these opportunities on their own time, I do think as employers, we should support the time that it takes for them to study and become proficient.
Yeah,
Benefit from it, right?
I've seen hospitals have study groups together and do flashcards and really promote the test itself and working together on it.
Awesome. Any final thoughts on NAHAM or HFMA?
No, I just think, they're both really great associations that anybody in revenue cycle and patient access should take a look at. And if you're not a member, you should really look into the value that comes with becoming a member. I think learning is super important for everyone, regardless of title. And if your organization offers any type of enterprise-wide membership, you should take advantage of what's available.
Awesome. All right. Well, let's go on that note out to a quick break, and we'll be right back.
At ValueWare, we help healthcare organizations streamline prior authorization submissions with one platform, helping you simplify, connect, integrate, and automate each part of the process. We take your pre-existing workflow and truly automate it, including the submission and verification process. The best part? ValueWare automates your prior authorization processes for all of your payers, specialties, and service lines, not just some of them. Valor is built around you. Learn more at valueware.com. That's valueware.com. Are you ready to unlock the full potential of your medical coding team? Look no further than Adeo Technologies, the leading provider of medical coding productivity solutions. With Adeo's Gemini Solution Suite, medical coders are empowered and complemented with cutting-edge tools and technologies. The Gemini Coder Platform, Gemini Autocode, and Gemini Coding Assist solutions work seamlessly together, creating efficiency and improving accuracy in medical coding. Say goodbye to tedious manual processes, cheat sheets, and memorization, and embrace the power of workflow improvements, artificial intelligence, and predictive coding. At Adeo, we believe in the collaboration between medical coders and artificial intelligence to create coding capacity that makes human coders more valuable to their healthcare organizations. Visit our website at www.adeo-tech.com. It's adeo-tech.com to learn why we love coders and how Adeo Technologies is transforming medical coding productivity one claim at a time.
And we're back.
All right, we're going to move to the debate. And as you all know, if you listen to our podcast regularly, in this segment, we discuss industry trends, out-of-the-box ideas, or topics that get you thinking. So now I'm going to read this almost verbatim here, just for leveling off our conversation today. Now that CMS has proposed rules, we continue to see one of the most talked about items in revenue cycle IT and revenue cycle management be around price transparency requirements. With the current rules in place, what are some of the challenges that the patient access community is discussing? I'll open that up to the group, but just thinking like patient access, price transparency requirements, what are maybe some of the big key call outs that we're thinking about just in the recent proposed rules from CMS? Who wants to take a first pass at that?
I can take a pass at that. I think what I hear the most is really just about the machine readable files. The nature of hospital pricing and rate negotiations doesn't translate easily into a single fixed rate per service. And so it's very complex. And, our patients encounter this when they're trying to either self-estimate or shop for services. Also, I think it's important to note that oftentimes, the file, it doesn't include the professional fees, such as like physician, radiologist, anesthesiologist charges, path fees. And patients don't always understand their health plan specific benefits or their out-of-pocket costs. And so overall, the patient access community, wants to provide transparency. But really what I often hear is it's more accurate to have trained healthcare access staff create the estimates versus the patients trying to read the file or creating their own shopper estimate. And honestly, I feel, and I've heard this from some of my other colleagues, is we'd really like to see, the health plans have more responsibility in having to provide transparency to patients and not just the organizations themselves.
Yeah, I agree. I think that there's, I think everyone's trying to do a good job with price transparency. I think there's estimates is the big player in this too, is making sure that that estimate is correct and getting that information to the patient. But yeah, I agree with everything you said there, Jack. We're trying to get there. I just don't think we're there.
Yeah, I agree with you guys. I think that, we're all organizations are intentionally meeting the intent of the law, right? And the law is to, in that regards, post your charge master, post what is your machine readable file, post what are your top payers and what's your negotiated contract rates. And I think that we're all a little still leery on that component of it because while it's transparent, intended to be transparent for patients, it's not the patients necessarily leveraging and using that. It's health plans leveraging and using that from our experience of looking at it, from a provider standpoint and saying, oh, okay, well, this is your negotiated rate with payer X. So now I'm payer Y, and I'm going to want that same rate because it's a better rate. But what they're not factoring in is how many covered lives is our organization anticipated to get from you? Do you have a direct where maybe you're only, your primary only in network in that space, and you're getting a better rate because of that, that type of deal. So I do think that lends to open things up. I think pricing transparency when we look at it and associated even with the balance bill, and I know I didn't bring this up in our prep call, but even with balance billing of like saying, hey, if you're an out-of-network physician group practice or anesthesiology practice and you're providing services at an in-network, you now have to take an in-network rate. I think that's the right thing for the patient, right? That's saying, hey, you're going to process it as an in-network rate. You're going to figure that out. The difficulty of that is on the provider side is, what is an in-network rate when I'm out of network, and how do I calculate that? Is it an average of it? And then am I negotiating that? I can't do single case agreements for every single account. That becomes tedious and manpower hours. So I think from a transparency perspective, it puts a lot of things out there for all of us to say, yeah, we do want to provide this information to patients, and we want to do it where it can be self-service, especially for, your Gen Zs, your millennials, the people who want to self-service and are accustomed to that. But at the same time, we've not educated the public and the consumers in what are CPT codes, what are diagnosis codes, what are the appropriate pairings of that. What's layman's term technology of that? What we're required to do is here's our procedural code and the CPT code, and here's what we call it. But there is no convention saying, hey, you have to use the Medicare, layman's term or the Medicare short description or primary. And then what happens when it's just a flat, surgical level? That means nothing to a patient, because then you have a surgical level out there and they're looking for that procedure right in your list, but yet no, it falls into a surgical level. It's coded by coding, so they need to call to get an estimate. And that's where I think we run into, are we double dipping and causing more work, and kind of how that's going to play out over time, especially as CMS continues to increase regulations associated to pricing transparency. And they have the right idea in mind. It's just they're putting it on the wrong, back to your guys' point, they're putting it back on the wrong team. A provider doesn't know a patient's network benefit, but the network knows what their benefit is. And they also know who they're contracted with and what they're going to pay that contracted rate at. That's if the health plan loaded their contract correctly too. That's a different podcast.
Yeah. I mean, just to give an example, Evan, I recently had surgery, and when my physician told me I was going to need to have surgery, he scheduled me for the surgery, and I immediately called my payer, my plan, to find out, okay, well, what's my out of pocket going to be? And my health plan told me that they couldn't tell me. I needed to call the facility because they didn't know the charges. And I was kind of frustrated with that, because all over the website it says, price, click here for care or whatever. They can tell me my physician charges, but they can't tell me my facility charges. So then I call the facility, and they're going to get me a pre-registration person, over the next couple of days. It's going to call me back with an estimate. And they call me back with an estimate, and the estimate's like $5,000 for my surgery. And I asked to have that, it seemed a little high to me. Could I have somebody look at that, review it? And they did, but that's what it was going to be. And so I paid because that's what it needed to be. But then my EOB comes in, and the EOB says I owe $238. But here I am in healthcare. I couldn't find out what the estimate was, what to look for. I'm asking everybody I know about the, estimate. The estimate that they give me is $5,000 based on what my plan says, what they think. So they're doing a good faith estimate. They did everything they're supposed to do. But the estimate says this is what's owed, but that's not what was owed. So it's just frustrating. It's frustrating, I think, for the staff. It's frustrating for the patient. And then, I think leadership then, though, behind the scenes, they think we're doing price transparency. We're doing a great job. We've got the machine readable format. We've got the information. We've got the estimate in place. But it's, from a patient experience perspective, it's not there yet.
Yeah, and I think that we run into, right, and like Jackie, I think you guys are experiencing this probably. I know one of your sister sites is experiencing this around ABNs, right? So if you're a Medicare patient and we overestimate by 20% or by $100, whichever is greater, you don't pay. You pay what that amount that you estimated was. That's all you can charge the patient, right? But you don't experience that when you're a commercial payer or you're an out-of-network patient or any of that. And I think the hard part is that even our contracting solutions on the provider side aren't necessarily always 100% accurate. We're loading a contract based off of the complexity, and sometimes the system can't even do the math for us. So that's why you see an overestimate or you see an underestimate sometimes as well. And there and nowhere does it, I know we all put this in our language on the provider side of like, hey, if you have a complication, you could end up paying more. But what does that really mean to the consumer? And I'm sure call centers, and Jackie, you probably get it from a patient who comes back for a routine procedure is like, am I going to pay more this time?
Yeah.
Yeah, no, I think, my staff, some of their frustrations that they've articulated to me is really, they work really hard to create these estimates, or we have the system creating these estimates. We've done a lot of build, right, over time and validation to make sure they're accurate. We have an estimate finalized, we present it to the patient, and the patient goes, this is wrong, right? And then we're stuck with going, okay, they think it's wrong, what's wrong? And you have a line of patients if you're on the front end. So you're trying to quickly understand, because you don't want to dismiss the patient, right? What it is that's wrong with it. And you'll have times where they're absolutely right. When we had originally quoted it, they hadn't met their deductible. But now they've had services since when we created the estimate, and now they've met their deductible. So their estimate is different. So then you have them next time when they're repeat customers, they don't even want to talk about an estimate with you because every time I come here, you get it wrong. So they lose trust in you.
Right.
And the staff are kind of caught in the middle with going, well, I'm being told by my leader, I need to provide the estimate. I need to have this, transparent conversation with the patient pre-service. And when I'm trying, the patient, either doesn't want to hear it or they get very upset by it, rightfully so, right? Because we've now quoted them wrong however many times, or we have it right, but because we've quoted wrong in the past and we're now confident, like we just re-reviewed your benefits, here it is, the patients don't believe us. So it's definitely challenging to be in patient access on the front end, trying to help patients, understand what the cost of their care is going to be.
It almost makes an argument that, like, if we are seeing inaccurate estimates, whether it's being generated by a person or the system, that like we do maybe, I think a lot of myself included, like if I was not in the ground or in the weeds on this, I might think, oh, we have some patient estimates like tools that they can go use, and there's a machine readable file. I just wipe my hands and move on. There's not a need to really invest in this further. But it sounds like there really could be a loss of patience or just loss of trust in our health system if we don't maybe take some effort to get these estimates in place. I know we've talked about the front end impact. Do you see these issues impact other rev cycle teams just across the system? Like, what are you hearing from your colleagues and peers?
For sure, the back end, I mean, the business office, they get the calls because we've either collected too much and now they want their refund, and they want their refund now. And they want to know why we collected what we did. And so they're kind of caught in the middle. And so I've had to do retraining or training with the business office to explain to them how we came up with the estimate we did, because in the very beginning, it was, they had no clue where we were getting the estimate and what information we were given to the patient. because there's always a disclaimer that's given to the patient that it is an estimate and et cetera. And so we want to make sure that we're consistent in that message, but then also the business office knows what's being relayed to the patients. When they get that call, they can handle it appropriately. But yeah, there was always an influx of calls and stress on their end as well.
Yeah, absolutely, Patty. And, even though our analytics team helped us create a report and we review it monthly to see estimate accuracy, we review those kind of overestimated and underestimated, et cetera, and different trends. Was it a patient? Was it a user? Was it the system, et cetera? We continue to see an increase too in patient calls and emails for estimate assistance, whether it's them not wanting to create their own, which is fine, and they want someone to help them with it, or the post-billing assistance. I talked to our SBO interim director, and she said, yeah, our phone calls continue to increase, and both areas, mine and hers, we've had to increase our hours of operations. We've hired new positions to help create estimates and handle patient inquiries. So it's definitely impacted revenue cycle teams as a whole.
Do you see it stretching beyond just the revenue cycle teams as well? I mean, I know, from covering from a back end perspective, they definitely see the brunt of it, or customers, the call centers are seeing the brunt of it. But is it impacting managed care contracting or even the physicians?
I'm not sure. I know I do hear sometimes from different physicians where it's more the physician is advocating for the patient and they want to know what the cost of care will be for them. So they are directing patients to our area. Central scheduling is decentralized here at UC San Diego Health. And so I do know that team, when scheduling patients, they're getting a lot of questions about how much it's going to cost them, are they in network, et cetera. And I know our contracting teams have created new web pages for patient inquiries. Whether or not it's all related to price transparency, I don't know. It could just be that we're seeing more and more patients who, like to shop around, and they're really good consumers and they want to know pre-service what things are going to cost them. But definitely have heard from a variety of sources that, patients are inquiring about what it's going to cost.
Are you guys doing estimates and pricing transparency come the new year? I mean, Patti, I know that you ran into this as you were covering for your last client. You and I were there for the dual changes twice. And also knowing that, Jackie, you're at an academic center that has a different fiscal year. So you're redoing pricing rates, I'll call it mid-calendar year. How are you guys tackling that with your estimates? And then also, providing that transparency back to patients and from a consumer perspective?
I think what we were looking at was retraining of staff, just making sure that they fully understood the regulations, and then also the estimates and what to do when they thought an estimate was wrong or that there wasn't an inaccuracy there, what to do, what steps to take. So we did some retraining, and then also just fine tuning the estimates, putting together a real strong QA process so that if there are outliers, what's going on with these outliers, just staying on top of the estimates.
Yeah, Patti, kind of the same here. First we try to make sure that we have all the correct stakeholders engaged in discussions early on. As you mentioned, making sure that staff are trained and up to date on the different regulations, that they understand clear escalation pathways to take, which is always important. And then, I think we made a commitment that, as frustrating as the price transparency legislation is, that we need to continue to remember that it's the right thing to do for our patients and for their experience. And, we really want to make sure that even if we have to go above and beyond the rule of law here, to make it meaningful for them, that's what we're going to do. So we're going to invest in continuing to do what's right for our patients and make sure their information we provide them is as accurate as possible.
Jackie, did you have non-revenue cycle team members go through the training as well?
We did.
Mm-hmm. We did too. Yeah.
Because it's very important, because you never know where the patient is going to pose their question, right? And you may not know the full answer, but if you have a high level understanding, like when No Surprises Act came out, right? Like if a patient came in and said, where's my good faith estimate? We didn't want someone on the receiving end going, what is that? We wanted them to be familiar with the terminology that could potentially be used, and for them to know who their resource is and where to get that patient to.
What are some of your guys' final thoughts on how organizations should, prepare for the changes with the new rules coming up, especially since they're just proposed still?
I think there's still a big disconnect between where patients can get the information. So they can get the information from the machine readable information. They can get it from estimates. They can get it from the No Surprises Act. They can get it from the transparency. It's all these different areas, but they're not tied to one another. So they're not feeding the same information. So there's room for error. So I think that we've got to get on the same page and make sure that we're giving the same estimate, regardless of where the patient's getting it from.
Yeah. And I think for us, obviously we're going to wait and see if anything changes, because oftentimes things change or get delayed, but we're ready to take action if we do need to standardize, how the information is formatted for our patients to be able to hopefully better understand what they're looking at. And so we're patiently waiting just to see what happens, but we are starting the discussions now just to make sure that we can hit the ground running when it becomes final.
Yeah, the proposed rule, I put a quick presentation together for one of our clients, and it's 15 pages of slides, like outlining what recommendations they need to have, where do they need to make modifications, and really the changes aren't really helping the patient at all. It's actually potentially going to add some additional confusion. And it would be nice to see. I think the biggest part of the proposed rule is there is language now to start to push back on at least the managed care, Medicare and Medi-Cal or Medicaid, or in your case of California Medi-Cal, like required some additional requirements there. I think the balance billing laws within the state level actually provide a little bit more in the transparency and estimate realm. I think better language of the intent than I think what some of the federal intent is right now. So it would be nice to see them adapt some of the state information and then the ease of it as well. So
do we need to send you to Washington, Evan? Get you in front of Congress?
No.
Go lobby for some change.
I am not a good lobbyist. Ask Patti. I just speak my mind and run.
Runs. Yeah.
All right. Well, let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
And we're back.
All right. Just to wrap up today's podcast, we're going to transition to the Wilshire Lab. Again, no direct questions from listeners. So if you're a listener out there, please let us know if you have questions or topics you want us to cover. But just to have some fun with our guests today, I want to have our listeners get to know a little bit more about you and get some advice. And so just pose a question. What is one major professional accomplishment you are most proud of? Patti, do you want to start us?
Sure. I would say that my biggest professional accomplishment that I'm most proud of would be of centralizing a pre-registration insurance verification department. I did that back in early days of 2006, 2007. So it was before centralization. And so that was a big initiative. Had to centralize it, take all the folks from hospitals, and that wasn't very politically. People were not happy, but it was a good move, and we were able to centralize and really do some really wonderful things as a result of that. So that would probably be my biggest accomplishment.
All right. So for me, I mean, I have a similar story there, but I think mine is really more of my personal accomplishment. So I'm most proud of earning my master's degree in business administration. I'm the first person in my family to attend college, and I did so while working full-time and raising 3 small children. It really helped me kind of realize my strength and my determination, that when I put my mind to accomplish something and you work hard, that anything is possible. And so professionally, it's really helped me address, I feel, more complex business challenges and to enhance my marketability. And I'm very proud to have received my graduate degree overall. Like Patti mentioned, I've had the opportunity to work at various organizations, and I also helped centralize or create an authorization team based on denial findings. And so being a new leader, it was my first management role. It's something that I still look back at and I think, wow, if I didn't have the fundamentals that I learned throughout going to college, I don't know if I would have been able to do any of that. So very proud of that.
So as we stick with the early careerist theme here, what's one piece of advice that you would give an early careerist for their own professional growth?
I think for me is really to think of yourself as a lifelong learner. Make it your goal to learn something new, which will help you reach any professional goals you have for yourself. And really to remember that employers are often interested in seeing that you're open to listening, learning, and growing in the role. And the more that you learn, the more of an asset you will become to your employer.
Mine's more like a networking, making sure that you develop those connections, network. You don't always have to reinvent the wheel. Always reach out to others, share best practices. Don't keep things internally. Just be sure to share and always reach out to folks. I think that's been probably the biggest benefit of my career is just networking and just having all the connections that I have, just being able to reach out to folks. And I think anybody realizes that they can reach out to me today and ask for something, and I'm going to, respond back with something, because it's just in my nature. That's what I want to do is figure out, the answer to their problem.
Okay, Daniel, before I let you wrap us, what's your most major professional accomplishment? Because you bypassed this. I went back and listened to the original episode. We asked each other these questions. So
I got off the hook. I didn't realize. Let's see. I don't want to take a cheater answer. I mean, I did not go to school to work in healthcare. That was like not something on my roadmap. I went for economics, thought I'd do like banking, finance, and it was like, I remember I had a 6-month gap because I graduated early. And so the only place that was hiring at the time was Epic. Like, who hires in February? And they hire apparently every month. So I was like, I'll do this for a little bit and I'll move on and go back to finance. And I think it's like, 8 years later, and I'm still doing this. And I've had the opportunity to go overseas. I've worked with over a dozen health systems, and I'm now a director in an operations role, which is really weird. So it's been a career that started from something that I had no interest. I didn't even know what it was. I showed up to the interview and I was like, I don't actually know what this company does or what healthcare is. I didn't actually know it was for healthcare. That was I'm surprised I got a job and landed in the industry, but I've made a career out of it, and that for me is unexpected and something I'm proud of, like sticking with it for as long as I have.
And you do a great job. Like Daniel asked some amazing questions to Patti, and I even stumped me this week. I had to go phone a friend from on one of his on where he's filling in as an interim director. So
it's fun. I learn something new every day. That's also, I mean, the lifelong learning. I don't think there's like a guide. I mean, we talk about like certifications and conferences and networking, but there's no like guidebook for any of our jobs.
No,
so I
there's
mean,
not.
to Patti's point about networking, like you do have to phone a friend for literally everything, because I don't think anybody could tell you this is what you're actually supposed to do every day. That doesn't exist.
yeah. All
Well,
right.
should we wrap up here?
Sounds
Thanks
good.
thanks Jackie and Patti for joining us, and for season 2, episode 21. Wow, that's so many episodes. The marriage between pricing transparency and patient estimates. For folks who want to reach out to you, the network, or just, I don't know, chat, grab tea or something on a Zoom call, what's the best way to reach you? And that can be any medium. Jackie, what about you?
Sure. So you can email me at jdjordan@health.ucsd.edu, or you can find me on LinkedIn as Jackie Jordan.
And I'm at p.consolver@thewilshiregroup.net. Is that right? Right.
That's right. All right. Well, I think that's it for us today. And quick shameless plug, we would love to have you. We're playing season 3. We'd love to get more listeners to actually join us on the podcast and share their thoughts about revenue cycle and healthcare IT and where we're headed. So if you would like to, please reach out to us at the Wilshire podcast at thewilshiregroup.net. And that's it for us today. Bye-bye.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at the Wilshire Group, or on Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at WilshirePodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.